Fine.
Yeah.
So approach to pancytopenia. So it's our pleasure to have none other than Dr. Manas Kalra, who is the Secretary of Pediatric Hematology Oncology Chapter of Delhi, Indian Academy of Pediatrics. Welcome, Dr. Manas, and over to you, sir.
Hello, hello, Mukesh. So, thank you for being here, all of you. And we have a case presentation which Dr. Mukesh and I are going to moderate. So, both of us are going to ask questions to Dr. Kashish, who's going to present the case. Dr. Kashish is a DNB trainee at Institute of Child Health, and she'll be presenting the case today, and then we will have a discussion. So, Dr. Mukesh, please feel free to stop wherever you want to stop, and then we can ask questions. And I think we should encourage all the participants to write the answers in the chat box, and they
Sure.
can pose the questions also, isn't it?
Bilkul, bilkul, bilkul. No,
So
without
that
any.
we have a good
They,
interactive discussion.
exactly. They should ask whatever they feel like.
Okay, great. So, Dr. Kashish, are you ready? Can you start presenting the case, please?
Yes, sir. Thank you, sir. Good evening, everyone. Myself, Dr. Kashish. Today, I'm presenting a case based on approach to pancytopenia. So, I'm presenting a case of a male child, 5.5 years age, informant his mother. He is religion, Muslim by religion. Date of admission was 14 July and date of examination was 16 July. Child presented with chief complaints of pallor for 2.5 years and easy fatigability for 2 years. The 5.5-year-old boy, second by birth order, born of non-consanguineous marriage, presented with complaints of progressive paleness of body since 3 years of age and easy fatigability from last 2.5 years. Patient had an episode of fever at 3 years of age, for which during a routine OPD visit, few investigations were done, which revealed low hemoglobin, and child was started on iron supplements. During follow-up, it was noted that child persisted to have paleness and low hemoglobin despite taking iron supplements on a regular basis starting from the age of 3 years.
Sorry, Kashish.
Yes, sir.
Dr. Anupam here. जब आप ये
Good evening, sir.
स्लाइड गुड इवनिंग जब आप ये स्लाइड बनाते हैं तो इस तरह नहीं बनाते हैं स्लाइड you just have to write the points and you have put about 10 lines. It should not be more than 6 lines. Okay, you should make the slides in such a way that they are more readable. इस तरह पैराग्राफ फॉर्मेट में नहीं चलता. ठीक है?
Okay, sir.
बेटा पॉइंट्स में लिखो और फिर उनको आप सेंटेंसेस अपने आप फॉर्म कर सकते हो. पॉइंट्स आर जस्ट लाइक रिमाइंडर फॉर यू so that you can say the thing, but then you have to form sentence on your own.
Okay, sir. Child was taken to multiple local clinics at their hometown, but then lost to follow-up from last 2 years. History of blood transfusion is present twice till date. First transfusion was done in March 2024, and second transfusion was done in 16th of July. Now, coming to negative history, there is no history of FICA. I have asked the history of FICA because of the most common cause of anemia is in India is nutritional anemia, and in iron deficiency anemia pica can be present. No history of worm or blood in stools. No history of any TB contact. No history of poor weight gain. Poor weight gain I have asked because of any malabsorption syndromes can result in anemias. No history of chronic diarrhea. No history of fever or weight loss. No history of jaundice or any edema or decreased urine output. I have asked for any chronic kidney disease. There is no history of high colored urine. Or there is no history of abdominal distension, no history of any gallstones or joint pain or any bleeding manifestation, no history of any radiation exposure, and pharyngitis, skin rash, recurrent infections, and no history of any herbal drug intake. No palpitation or breathlessness was noted, and no history of bone pain, abdominal pain, or premature graying of hair. Now coming to family history, child is a product of non-consanguineous marriage, second by birth order, no history of blood transfusion in family, and there is no history of splenectomy, bleeding tendency, jaundice, or gallstones in family. Antenatal history. Mother's age at the time of conception was 27 years. Anemia workup was done in first trimester, revealed iron deficiency anemia. So iron and folic acid supplementations were given during pregnancy to mother. Now, birth history. Child was delivered at term by LSCS. Birth weight was 3.2 kg. There is no history of NICU stay, and there is no history of excessive bleeding from cord at the time of birth. Development history. Child development is adequate for age. Child studies in first class and is average scholastic performance. Immunization history is completed up to age as per NIS protocol. And dietary history, child is non-vegetarian and daily calorie intake is 1120 kilocalorie per day. Daily protein intake is 20 grams per day, which is adequate for this age. And so, sir, on the
Wait.
Sir,
Let's
you-
go back to the history.
बेटा
हाँ, आप
summarize
क्या कह रहे थे? आपका
summarize
क्या
करो बेटा.
था? हाँ, समराइज कर दो और फिर वापस हिस्ट्री में जाएंगे. समराइज कर दो फिर वापस हिस्ट्री में जाएंगे.
Yes, sir. So 5.5-year-old male child presented with chief complaints of pallor, which has started from the age of 3 years, which is gradually increasing. And from the last 2 years, he is taking multiple like iron supplementations, but the anemia is still there. And the main symptoms child is having is only anemia and the easy fatigability. So pallor and easy fatigability.
No, you said there are history of 2 blood transfusions till date.
So yes, sir. Though 2 blood transfusion.
So,
The first transfusion was
at what age? First transfusion was at what age?
first transfusion was done in March 2024, sir. Like 4 months back only.
So
At
that
5
means
years of age.
5 years. And second?
Second is now only at 5.5 years.
5.5 years. So it was PRBC both times?
Yes, sir. PRBC transfusion.
Both times it was PRBC transfusion.
Yes,
Right.
sir.
So any other history which you would like to take, which you may have missed, though you have elaborated it well.
So history of any recurrent infections or bleeding manifestation.
You have mentioned that, right?
Yes, sir.
So go back to your negative history.
Yes. Sorry.
Yeah. Can you elaborate why you have asked all these things?
Yes, sir. History of pica I have asked for iron deficiency anemia, and history of worm and blood in stools because of the worm infestations can lead to the loss of blood in stools, so it can cause anemia. History of TB contact I have asked because of in case of
कशिश, अगर
Yeah.
अगर बच्चा वर्म पास नहीं कर रहा तो भी क्या उसको वर्म इन्फेस्टेशन हो सकती है?
yes sir हो सकती है.
कौन सा वर्म? कौन सा वर्म्स ऐसे होते हैं जिसमें हिस्ट्री ऑफ पैसेज और वर्म नहीं होती? हिस्ट्री कौन सा वर्म इन्फेस्टेशन होता है जिसमें नहीं, हिस्ट्री में पता नहीं चलेगा कि वर्म पास हो रहा है नहीं हो रहा? हुकवर्म कितना क्या साइज होता है हुकवर्म का? हुकवर्म दिखता है नेकेड आई से? हुकवर्म दिखता है?
No sir.
कॉमनेस्ट कॉज ऑफ एनीमिया कौन सा वर्म है?
Hookworm sir.
तो हो सकता है ना ऐसा?
Yes
तो
sir.
आपसे मैं यही तो पूछ रहा हूँ कि ठीक है आपने हिस्ट्री नो हिस्ट्री ऑफ वर्म पूछा है, मेरा क्वेश्चन आपसे कि अगर वर्म पास नहीं हो रहा तो भी क्या हो सकता है? हो सकता है ना?
Yes sir. Yes sir.
हुकवर्म का क्या नेम क्या होता है, मेडिकल नेम क्या होता है हुकवर्म का?
Ascaris lumbricoid.
एस्कैरिस हुकवर्म होता है?
So and cyclostoma duodenale.
तो आपको पता होना चाहिए ना बेटा, ये तो वर्म आपको पता होना चाहिए ना, है ना? ब्लड इन स्टूल आपने बोला सेकंड पॉइंट. ब्लड इन स्टूल किस कंडीशन में बच्चे को फ्रैंक ब्लीडिंग इन स्टूल होता है बट बच्चा बिल्कुल ठीक होगा और फ्रैंक ब्लड इन स्टूल? एक तो जो स्टूडेंट हुआ है हु इज प्रेजेंटिंग ना शुड पुट देयर वीडियो ऑन.
Oh, sorry.
The students who are presenting should put their video on anyways. बट मुझे बताओ कि ब्लड इन स्टूल में आप क्या, कौन सा ब्लड इन स्टूल में फ्रैंक ब्लड इन स्टूल आ रहा है, बच्चा बिल्कुल ठीक है, क्या कंडीशन होगी? मुझे एग्जांपल दो.
So
कोई एग्जांपल दो जिसमें बच्चे को फ्रैंक ब्लड इन स्टूल है.
yes sir.
which can repeated blood in stool, which can lead to anemia.
Sir, in case of any vessel injuries or angiodysplasia.
Commonly क्या होता है? Polyp वगैरह होता है ना?
Polyps, yes sir, polyp.
Polyps होंगे तो उसमें से bleeding हो सकती है ना?
Yes sir.
हो सकती है ना?
Yes.
वापस जाओ, आपकी अपनी हिस्ट्री आपने चेंज कर दी, हिस्ट्री पे जाओ वापस। हाँ ठीक है, तो डॉक्टर मुकेश ने कहा ना एक एक करके हिस्ट्री के बारे में वो डिस्कस करना चाहते हैं, तो हर का पॉइंट का आप जो कॉज बोल रहे हो उसको आपको डिटेल थोड़ी पता होनी चाहिए, है ना? अब नो हिस्ट्री ऑफ टीबी कांटेक्ट क्यों इम्पोर्टेंट है यहाँ पे?
So in case of TB, pulmonary hemorrhage can occur. It can lead to bleeding. So, and
पल्मनरी
in case of
हेमरेज है यहाँ पे? पल्मनरी हेमरेज है?
no sir.
कोई ऐसी कंडीशन आपको पता है जिसमें पल्मनरी हेमरेज हो सकती है और जो पता ही ना चले कि पल्मनरी हेमरेज हो रही है? कोई ऐसी कंडीशन है जिसमें बच्चे को पल्मनरी हेमरेज हो रही है, पता नहीं चल रही और एनीमिया हो रहा है? ऐसे कोई एक दो एग्जांपल दे दो। आपने कंडीशन सुनी है? आईपीएच, इडियोपैथिक पल्मनरी हीमोसिड्रोसिस।
Yes sir.
ठीक है, पढ़ना इसके बारे में। ओके
Okay sir.
हाँ, आगे चलो। डॉक्टर मुकेश आप भी पूछते रहो साथ साथ।
केस कवर्ड वेल। सो बेटा क्रोनिक डायरिया में क्या पूछना चाह रहे हो आप?
So chronic diarrhea, in case of malabsorption syndrome, chronic diarrhea can be
कौन सा
there.
malabsorption पूछ रहे हो बेटा?
In
मतलब
cause of
आराम से
celiac,
शांति से बताओ। celiac, okay
celiac
fine.
disease.
Anything else?
Or so in case of malabsorption can be occur in case of pernicious anemia also.
Fine, it can be inflammatory bowel disease also. Go ahead.
But
So
inflammatory,
history of fever
yes.
and weight loss, again you are trying to say TB or something else?
So fever or weight loss in case of TB also, and in case of leukemias, child is having
So
similar
he would have
complaints.
many more other things rather than just fever and weight loss if you're trying to see for malignancy. So jaundice, why do you want to rule out jaundice in a case of a simple child having a pallor not responding to iron?
So jaundice, in case of hemolytic anemia, jaundice can be present. So that's why I asked you.
Okay, fine. Edema, decreased urine output?
The edema decrease in case of CKD, CKD patient can present with anemia. So that's why I've asked, sir.
CKD.
Because of decreased erythropoietin levels.
Okay, go ahead, Kashish. Go ahead.
अच्छा, एक और चीज बता दें, अगर सीकेडी हो तो क्या इंक्रीज यूरिन आउटपुट हो सकता है सीकेडी में? वैसे ही पूछ रहा हूँ
सर।
कोई सीकेडी का कोई कॉज जिसमें इंक्रीज यूरिन आउटपुट हो सकता है?
In the initial stages of CKD, it can be there.
और चल आगे चल, नेक्स्ट स्लाइड।
Yeah, I think she can go ahead. Go ahead and better summarize your case.
Okay, sir. So this is a 5.5-year-old male child presented with chief complaints of pallor and easy fatigability from last 3 years. And in last 6 months, there's 2 episodes of blood transfusion I've done. Last transfusion done in July, like 16th of July 2024.
So go back to your differentials, right? So
yes.
These are your differentials. So this
Yes,
is so it's a 5.5-year-old child with progressive pallor since 2.5 years of age, receiving some iron therapy, not responding, and now this child has required 2 PRBC transfusion, one 6 months back and second one just prior to this presentation. So your DDs are nutritional deficiency, iron deficiency, B12, bone marrow suppression, and hemolytic. Okay, points in favor and against.
Sir, the most common cause of deficiency is nutritional deficiency. That's why I have put nutritional deficiency in the first place. The child is having a progressive pallor and easy fatigability. That's why I have put iron deficiency, anemia, B12 deficiency, folate deficiency can present with
कौन
this.
सी ऐसी nutritional deficiency होगी जिसमें 2 बार PRBC की requirement हो जाएगी? Well, it is just for your learning. Don't feel
Yes.
bad. So, can you explain
In
the
case of
nutrition
severe,
deficiency in 2 PRBC transfusions?
yes, a 2 PRBC transfusions are done.
So, how can you explain the nutrition deficiency?
In
2
case of
PRBC.
severe anemia, sir, we can transfuse.
बेटे सर ने ये क्वेश्चन इसलिए पूछ रहे हैं कि वो देखो हिंट दे रहे हैं कि जनरली न्यूट्रिशनल डेफिशिएंसी में ना बार बार खून की जरूरत नहीं पड़ती है। रेयरली हो सकता है कोई बिल्कुल ही खाना पीना ठीक नहीं किया, बिल्कुल ही दवाई नहीं ली, एक बार दे दिया उसके बाद भी वैसे ही के वैसे ही रहे, बिल्कुल सुना नहीं। बट जनरली क्या होता है, एक बार खून चढ़ा दिया, आयरन दे दिया, एपेटाइट इंप्रूव कर जाती है, बच्चा ठीक हो जाता है, फिर बार बार खून की जरूरत नहीं पड़ती। इसलिए दैट पॉइंट इज लिटिल बिट not very much goes with the nutritional. That is what he is trying to hint. ठीक है?
Okay, what do you feel is the cause, points in favor and against bone marrow suppression?
So, as a child is having a chronic anemia, so like only pallor is present. So, the bone marrow suppression syndromes can be there. Like a few syndromes, Fanconi anemia can present at this age.
So you mean to say inherited bone marrow failure syndrome?
Inherited bone marrow
which we don't know.
syndromes.
Which we don't know. We haven't examined the child, so we don't know. Fine.
Yes.
So what are the points in favor of hemolytic anemia in the history?
So in history only pallor is present, sir, and the transfusion has been given. That's I have put hemolytic anemia, but jaundice and most of gallstones. So that's why I have put it in third order.
बेटे एक चीज और, जब तुम बोन मैरो सप्रेशन बोलते हो ना,
Yes, sir.
बोन मैरो सप्रेशन का मतलब होता है एक 1 लाइन सप्रेशन, 2 लाइन सप्रेशन, 3 लाइन सप्रेशन। तो अगर
Yes.
आप ये बोल रहे हो इस केस में जिसमें सिर्फ बच्चे को 2 बार खून चढ़ा है, ना कोई बुखार आ रहा है बार बार, ना उसको ब्रूजेस हैं, ना ब्लीडिंग है, ना गम ब्लीडिंग है, कभी कोई दाग धब्बे नहीं आए हैं, बच्चा बार बार इन्फेक्शन के साथ एडमिट नहीं हो रहा, तो आप बोन मैरो सप्रेशन बोलो तो आप ये बोल सकते हो कि one of the DDs can be bone marrow suppression, that there is a red cell suppression, because by history you cannot really say कि ये बच्चे का bone marrow पूरा suppressed है, because
Yes.
white cell, तुम्हें रिपोर्ट पता है नहीं पता वो मुझे नहीं पता, बट इस समय बाय दिस हिस्ट्री जिसमें बच्चे को 2 बार खून चढ़ा है, मेरे पास कोई बच्चा आएगा कि मेरे पास 2 बार खून चढ़ा है, तो भाई मैं फर्स्ट डीडी मेरा बोन मैरो सप्रेशन नहीं होता। ठीक है? अब बोन मैरो सप्रेशन आपने जो सेकंड डीडी बताया, इसका कंडीशन का नाम बताओ जिसमें बार बार खून की लाल खून की जरूरत पड़ती है, ओनली child requires only red blood transfusion. Please give the example of bone marrow suppression. What is that condition?
Sir, pure red cell aplasia.
What is the other name?
Sir, diamond blackman anemia.
When does the child present? What is the age when the child first presents usually?
Sir, during 1 year, sir.
Infancy. Usually they present with infancy. And what is a common differential at that time? If a child presents with, isolated anemia, if you
thalassemia, sir. Thalassemia at 6 months of age.
Thalassemia also presents generally in infancy. Okay, so
Yes.
those are important DDs, and that comes like a hemolytic anemia. So,
Yes.
by this history, are you able to say this is hemolytic anemia?
But no, sir, only pallor is present, so we can't say it's hemolytic.
So tell some hemolytic anemias that can present in infancy other than thalassemia.
Sir, hereditary spherocytosis can present.
How does it present in infancy? Hereditary spherocytosis?
Sir, pallor and jaundice, with complaints of pallor and jaundice to present.
What is the typical thing? Usually what will they have? Hereditary spherocytosis.
No.
Anything in the first month?
Sir,
neonatal prolonged jaundice.
Jaundice, prolonged jaundice.
Neonatal jaundice, neonatal recurrent jaundice, need for prolonged phototherapy, all that can be there. That can be one of the manifestation. What else can, how else can other hemolytic anemias present in infancy?
Whether, sir,
1 or 2 years, something, one typical presentation will be there of a hemolytic anemia. If you live in, huh?
Increase in spleen size, sir.
Children will not present with increase in spleen size. If you suppose you live in Madhya Pradesh and
Yes.
a child comes to you, to 1.5, 1 year old child, crying,
Yes.
has got swelling in the hand.
But what sir is trying to ask is whether this child has congenital hemolytic anemia or acquired hemolytic anemia. So maybe what are the pointers in the history, or maybe later on in the examination, which can differentiate or delineate whether we have acquired hemolytic anemia or congenital hemolytic anemia.
Okay, sir. So acquired hemolytic anemia generally present in late childhood, and so like acquired hemolytic anemias include like autoimmune mediated. So other autoimmune disorders can be present with them.
So what are the other things in the history which can help us to delineate whether it's acquired or congenital? What is the type of onset in acquired and congenital one?
In congenital, so it's usually present in early stages of life,
it is
within 1 year.
insidious. It is early and insidious. Anemia in congenital ones are usually mild. In few cases, it may be severe, but in acquired, like AIHA, they are usually severe. And subsequently, the bone changes, spleen size, are the other things which may manifest more with. If things are persistent, they tend to be more with congenital ones, right? So I think
also I was asking about this hand swelling and the pain in the hands.
ये तो बड़ा important है.
Bone pains, sir, in case of sickle cell anemia.
Sickle cell. What is this? What is this called?
Sir, crisis.
Starts with D.
No, sir.
Starts
this
with
is a
D.
microvascular.
Starts with D. D for
dactylitis.
Right.
Dactylitis. Yes, dactylitis.
So these are usually present in specific areas of India. We do not suspect if the parents or the child do not belong to that area unless proved otherwise. So we tend to suspect when they belong to that particular area of
what area? What area, Kashish? Dr. Mukesh is hinting at some area. What area he's talking about? What is that called area?
For sickle cell anemia, sir?
Yes. Where do you see sickle cell anemia in India?
Sir, in Maharashtra, south side.
Okay, Maharashtra. Then? Have you heard of a Vidarbh area? Vidarbh area. Have you heard of Vidarbh?
No,
have you
sir.
heard of, you have heard of the state Chhattisgarh?
Yes, sir.
Madhya Pradesh, Maharashtra, Gujarat. There is like a belt.
Yes, sir.
There is a belt where you can see patients with sickle cell anemia. Okay, so you have to ask history. Where does the family belong? Every child you have to ask a history. Where do you belong? If you have a child from Chhattisgarh who presents with anemia requiring recurrent blood transfusion, my first DD will be whether it is sickle or not.
Yes.
But you have to ask that history, na?
Yes.
Okay.
Okay, sir.
I think you can go ahead.
Okay, sir. So on general physical examination, child was conscious, oriented to time, place, and person. Child was examined in the supine position. Heart rate was 120 per minute. In right radial artery, it was good volume. No radial or radiofemoral delay was there. BP was 92/60. mmHg in supine position. Measured in right brachial artery in sitting position. Respiratory rate was 28 per minute, and temperature was 98 degree Fahrenheit. On a head-to-toe examination, pallor was present, but there is no icterus, cyanosis, clubbing, or lymphadenopathy. And there is no hyperpigmentation or any hypopigmenting areas on skin, no dysplastic or hearing dysplastic like ear abnormalities was there, and both upper limb and lower limbs are normal. There is no dislocation or any other abnormalities. No malar rash, hyperpigmentation will be present.
But you said there is no icterus. Okay.
Yes, sir. Yes.
I'm saying that I'm saying that your patient has got hemolytic anemia. Okay.
Yes, sir.
Now tell me some hemolytic anemias
Yes,
where
sir.
when you are examining, you may not see icterus.
Sir, in G6PD, the mostly
Okay, good. Because it will have intermittent jaundice. Good.
intermittent
What else?
jaundice. And sir, in case of sir, PKD pyruvate kinase defect, sir.
Generally, you should say mild PK, mild pyruvate kinase deficiency. Because again, they may have intermittent jaundice worsening with infections. Even mild hereditary
Also,
spherocytosis, you may not appreciate jaundice very much, but generally they will have some icterus. What about thalassemia?
yes, sir. Thalassemia is mostly present with the pallor only, sir.
There is
Because
no
it's
jaundice in thalassemia. There is no jaundice in thalassemia.
sir, mostly these patients don't have
They
jaundice.
have.
Most common
Which
presentation,
thalassemia does not have jaundice? Which thalassemia does not have jaundice?
sir, thalassemia intermedia.
No, they will have jaundice. Minor does not have jaundice. Intermediate, major will have jaundice. So you can appreciate little bit of yellowish, sclera. Whereas in thal minor, they don't have jaundice.
Okay, sir.
So some of the conditions will have intermittent. Generally, hereditary spherocytosis. What is the triad of hereditary spherocytosis?
Triad, sir. Sir, anemia, jaundice, splenomegaly.
Anemia, jaundice, splenomegaly. Okay. Sometimes when you have a intravascular hemolysis, you
Yes,
may
sir.
not, appreciate jaundice very early. It may appear little later. Okay.
Okay, sir.
Generally, the chronic extravascular ones will always have some bit of jaundice that you will see in the patients.
Okay, sir. Shall I continue, sir? So on anthropometry examination, weight was 19.1 kg, which was between 50th and 75th centile, and height was 122 centimeter, which was above 95th centile. So on systemic examination,
But on
the
general examination, did you mention about the skin color?
skin, so hyperpigmentation I have mentioned, any hyperpigmentation or spots.
Okay. You've written that there is no hyperpigmentation. Okay. Why did you ask for malar rash?
Sir, malar rash in case of,
5-year-old boy, why are you asking for malar rash?
sir, in case of connective tissue disorders, it can be present, but most common presentation is in adults.
Connective tissue disorder in this case
No,
doesn't make
no, sir.
like that you can ask so many other this thing. Why are you mentioning cafe au lait spot? Because
The cafe au lait spots can be present in the syndromic anemias, like in case of Fanconi anemias, can be present. That's why.
so Fanconi anemia, what should you mention? If Fanconi anemia is one of your DD, what should be you mention in the head to toe examination more?
Sir,
What should be there in your head
yes.
to
Sir, the thumb abnormalities will
okay.
be present in Fanconi anemias. Radius
So
will be
you have
absent.
written there is no
Yes,
thumb
yes,
abnormality.
yes, sir. Upper limb. I have mentioned the radius
Say head to toe. Go from head to toe.
Okay, sir.
Go from head to toe.
So yes, sir. Hairs were normal in texture. In eyes, there were no abnormalities.
नहीं
No
सर
torsions, no.
पूछ रहे हैं Fanconi anemia में head to toe में क्या
Okay,
मिलेगा?
okay. Sorry, sir. Sorry. In Fanconi anemias and eyes, there will be ptosis will be there, and hypertelorism can be there. In mouth, leukoplegia can be present in Fanconi anemias, and Strangle shoulder deformity can be present in Fanconi anemias. Then upper limb.
Leukoplakia is common in which condition? Leukoplakia is common in which inherited bone marrow failure syndrome?
Sir, in case of disc keratosis congenita,
DKC.
it's
It is
present.
seen in
But
DKC.
in DKC, it's present in the buccal mucosa. In Fanconi, it's present on the palate, sir. Mostly.
Okay. ऐसा होता है क्या? I didn't know this. ऐसा होता है क्या, Mukesh? I am also learning.
So it's like
Every
leukoplakia is
day.
common in its, but the next statement what she said, I'm not sure. In fact, I don't agree.
You have to mention facies. You have to mention the facies of the child. Did
Yes,
you
sir,
mention there is? ये कहाँ लिखा है आपने कहीं? No dysmorphology लिखा है कहीं? ये कहीं तो लिखा ही नहीं आपने. No dysmorphology लिखा ही नहीं आपने. facies normal है या नहीं है आपने ये कहाँ लिखा? माइक्रोकेफेली है या नहीं लिखा कहाँ है आपने? आपको फैंकोनी थंब एबनॉर्मैलिटी वर्ड आपने वर्ड ही नहीं लिखा. थंब नो थंब एबनॉर्मैलिटी. Because we are trying to look for particular thing because your diagnosis is, you said one of the DD is bone marrow failure. So you have to mention those particular things which are very typical about this case. इसमें मालर रैश का कोई significance नहीं है. Okay?
Okay.
Read about all the abnormalities that you see in Fanconi and try to see what all easily you can in your head-to-toe examination you can look for and you can mention. Okay?
Right. Dr. Manas, if you allow me, let me summarize what are all features we can see from head to toe in inherited bone marrow failure syndrome. First of all, in growth, we would expect growth retardation. In head circumference, we would expect it to be on a lower side, few centiles lower than the second centile and probably third. In eyes, we expect that there could be cataract, coloboma, squints. In the face, we could have dysmorphic features. In the mouth, we may have leukoplakia, teeth caries, high arch palate, and in the mandible, it could be retoganthia. In the neck, we could see the reticular skin changes. In the chest, we may have some congenital malformations. In the arms, in the hands, we may have abnormal absent radial artery pulses, abnormal thumb, which could be absent, hanging by thread, bilateral, triradial, and it's like absent, and hypothalamic eminences. And then if we see the genitalia, it could be, if there's a male child, it could be hypophallus, hypospadiasis, and going down in the lower in the limbs, and capillary spots, definitely to mention. And if in lower limbs, it could be syndactyly and absent thumbs. These are the things which we definitely would like to see whenever we consider inherited bone marrow failure syndrome.
Like an exam going student, Dr. Mukesh has nicely summarized it for you. Okay? So you should read about all the features that you can see and try to mention that in your head. It should be relevant for the case. Okay?
Thank you.
Next.
So on systemic examination, sir, per abdominal on inspection, shape was normal, flanks were normal, and the umbilicus was in center, and there is no discharge from umbilicus. All no distended veins were there. Hernial orifices were appear normal, and external genital examination was also normal. On palpation, there is a abdomen feels soft on palpation, though no liver or spleen were not palpable on examination. On palpation, and there's no organomegaly, kidney is not palpable. On percussion, resonant note heard, and on auscultation, ball sounds are present. CNS examination, child was conscious, alert, and active. No cranial abnormality were noted. On motor examination, bulk and tone were normal in both upper and lower limbs. Moving all for limbs, bilateral knee-jerk reflex was present, bilateral plantars going down, and no sensory involvement was there in the patient. CVS examination was also within normal limit. While tachycardia was present, otherwise the CNS examination was normal. S1, S2 are heard, and no added sounds were there. On respiratory examination also, on auscultation and palpation, it was normal. Bilateral air entry was there, normal vesicular signs, and there was no added sound on auscultation. So
Before you
So
go on
on
to
the
differential, summarize your case, beta. Before you go on to differential, summarize your case.
So, yes, sir. The 5.5-year-old male child presented with chief complaints of pallor, started at age of 3 years, along with the easy fatiguity, started uh, from last 2.5 years. And he's having 2 episodes of blood transfusion in last 6 months. And he's also taken, like from last 3 years, he's taken the iron supplements also, but anemia is still there. On general physical examination, there was no dysmorphic faces, and the uh, on systemic examination was also within the normal limits.
Go ahead with your differentials then.
So, sir, on the basis of history and examination, my differentials are nutritional anemias, aplastic anemias, MDS, and the PNH. Sir.
PNH,
Points
have
in
you seen
favor
any
and
case of
against in
PNH? Have you ever seen any case of PNH?
Sir, no, sir. Most common presentation is thrombosis वैसे in case of PNH.
PNH तो यार बहुत बड़ा तूने differential दे दिया.
Beta, points in favor and against in nutritional anemia.
So nutrition anemias, so child is having chronic anemia, easy fatiguability, and on examination there is no hepatosplenomegaly, no lymphadenopathy is there. So I have good nutrition anemia, sir.
So how would you explain
And,
PRBC transfusion?
yes, PRBC transfusion in so that
Okay. What about your second differential? What do you all try to include by saying aplastic anemia? Or it is just idiopathic aplastic anemia which you are trying to incorporate in your differentials? Points against and for.
child is having a chronic history of anemia from the age of 3 years, and multiple iron supplements have been given to correct the anemias, but still child is having symptoms, and the age is also like he's 5.5 years old. So that's why
aplastic anemia का बेटा aplastic anemia का बच्चा पिछले 3 साल से बैठा हुआ है, not requiring IV antibiotics, not having fever, not having bruises, not having bleeding. Is it common? Aplastic
no,
anemia.
sir.
Then
No, sir, it's not common, but
then what is more
it's
common? What is more common? What type of aplastic anemia can be more common in such a situation?
Sir, hereditary causes they can present with progressive deterioration of the blood parameters. That's why.
Acquired aplastic anemia doesn't present like this generally. You can say that, it can be some form of a bone marrow failure where there is mainly red cell failure.
Yes, sir. Hereditary causes, I have said, sir. Acquired mostly have acute presentation. So.
It's not like that. So the acquired ones usually, and even the inherited ones usually present around the end of first decade. But some subsets of inherited bone marrow failure present early. So in this age group, something presenting with only your PRBC requirement without any significant finding on examination, what particular inherited bone marrow failure syndrome at 3.5 years of onset?
Fanconi anemia.
Fanconi. So Fanconi, I just mentioned, it usually presents around the end of the first decade. Yes, it can present early. I do not say that it cannot, but what specifically, something more specific for
pure red cell aplasia.
So what in pure red cell aplasia? DBA?
Diamond fluorescence in anemia, yes, sir, it can present.
Yeah, they usually present in infancy, but yes, they can present later on also. So only PRBC requirement. If you see, aplastic and transphase covers idiopathic and inherited both. So
Okay, sir.
idiopathic is totally acquired ones, and inherited bone marrow failure syndromes, kind of it's a huge spectrum in which the Fanconi anemia is just a part of it, not the complete inherited bone marrow failure syndrome. So there are many other inherited bone marrow failure syndromes which can present with like this.
Okay, sir.
MDS, how did you think of MDS?
Sir, myelodysplastic syndrome, these
Arey,
patients are,
when would you suspect MDS?
sir, if patient is having like recurrent infections, if there is any bleeding or
नहीं, infection
infestation,
कहाँ है? इसकी infection तो है नहीं इस बच्चे को, इसको तो PRBC transfusion
there's anemia.
सिर्फ anemia है, तो MDS कहाँ से आ गया? तो इसमें अगर आपको दोबारा अपॉर्चुनिटी मिले to review and to put your differentials, how would you like to reorganize your differentials?
Reorganize. So first could be aplastic anemia.
So
Because
what
he
in
is having
aplastic, acquired or inherited ones?
the inherited
Why?
anemia.
बेटा ये बोलना पड़ेगा आपको, why?
Sir, uh, sir, like I have said, the chronic presentation hai and uh, blood transfusion की history है, sir,
early
age,
that is
late,
the most important. जल्दी बच्चा present कर रहा है ना, that is the
early
बड़े बच्चों
presentation.
के, हाँ, तो जल्दी early presentation, chronic presentation.
Yes, sir.
वेरी गुड, नहीं दिस इज फाइन. सो अगर मान लो ये ए प्लास्टिक ना हमारा इडियोपैथिक है ना हमारे, जो हमारे सबसे पहले डिफरेंशियल इफ यू आस्क मी, इट वुड बी ए प्लास्टिक एनीमिया. इन ए प्लास्टिक एनीमिया आई वुड लाइक टू कीप इनहेरिटेड बोन मैरो फेलियर सिंड्रोम. सपोज इनहेरिटेड बोन मैरो फेलियर सिंड्रोम है, तो नेक्स्ट डीडी क्या रखेंगे आउट ऑफ दिस?
Sir, sir, out of these, so in case of severe iron deficiency, blood requirement can be there, so we can put
Very,
blood
very,
relation.
very odd, but very, very odd. Yes, rarely I cannot disagree, but it would be very odd. Suppose it's not like this. So iron deficiency के साथ add on क्या हो सकता है बेटा? Add on बोलो. Yes, it is feasible. Occult blood loss, which we cannot say from the history, which investigations are going to tell us. So your second differential is totally right. Plus, if you add occult blood loss. Okay.
Okay,
So
sir.
aplastic anemia and nutritional anemia. What is your third differential if given a chance again to review?
So among these, third.
इनको तो छोड़ दो. Go ahead beyond these four.
Okay, sir.
Forget PNH, forget MDS, beta. They are very rare. Don't talk about PNH, MDS. What else? Other causes of anemia. What else can be the lead to this?
Sir,
हो तो सकते हैं ये भी.
thalassemia,
We cannot totally disregard them, but
Definitely they are possible, but they are rare.
Unlikely.
okay, sir.
What about anemia of chronic disease?
Exactly.
Yes, anemia of chronic disease. In case of
Can you
any
name some
kidney
chronic?
involvement.
Can you name some chronic diseases which can present with anemia?
Okay, sir. Sir, SLE, connective tissue disorders.
Connective tissue disorder presenting with anemia क्या common होगा 5 साल के बच्चे में? SLE, male child में SLE common होगा?
Sir,
Name a rheumatological condition. I'm not saying it is fitting into this condition, but I'm saying just name a few rheumatological conditions that can present with anemia in this age. I'm not saying it is fitting into that, but just asking. Can Sogia systemic onset JIA present like a chronic anemia?
So
Can
it
JIA
can
present?
present, but mostly
Mostly with what is the typical history?
so mostly they're having arthralgias and
And
fever,
fever.
arthralgia, most symptoms they
But that is one of the cause for
yes,
chronic anemia. Then you said kidney disease is one of the chronic anemia cause.
yes,
What else? Name a few other chronic conditions that can present with anemia.
hypothyroidism, endocrine
Okay, hypothyroidism. What type of anemia you see?
macrocytic anemia.
Macrocytic anemia. Okay, what else?
So in chronic liver disease.
ओके और सर ने दो आपसे पूछे थे ना जब
Wilson's.
आपने
Yes,
जब शुरू में कोई नेगेटिव हिस्ट्री बोली थी तो दो डीडीज बोले थे आपने सीलियाक इन्फ्लेमेटरी
yes,
बाउल डिजीज
yes,
है ना दे आर
yes,
आल्सो क्रॉनिक इलनेसेस ना वेयर यू कैन प्रेजेंट विद एनीमिया ओके
yes.
सो फटाफट पांच छह नाम बोलने हैं ताकि वी कैन प्रोसीड विद द डिस्कशन फर्दर ओके
Okay, sir.
चलो बेटा, go ahead.
So, sir, coming to investigation. So, initial investigations were done in 2021, and from there, at that time, hemoglobin was 6.8, TLC count was 8,000, and platelet count was 1.7 lakh. But gradually, the blood parameters decrease, and now the current values, which are done in July 2024, it was a hemoglobin dropped down to from 6.8 to 5, and TLC count was 3,300. Platelet count was around 1.09, and so MCV was initially it was as per the age in 2021 it was a lower side, but now it was like almost within normal limits, and retic count was decreased, like less than 2%, is 0.9% now. And RBC
बेटा
count is
एक
also
काम करो एक पहले आप सारा सीबीसी भूल जाओ आप फर्स्ट सीबीसी देखो सितंबर 2021 लुक एट दैट सीबीसी सितंबर
yes.
2021 can you please comment on what this CBC shows what is the age of the child what does that CBC show just comment on that
Okay, sir. Sir, at that point in 2021, child was having anemia, like hemoglobin was low, 6.8, but TLC and platelet counts are within
no
normal limits.
classify the severity of anemia what is
So
the
severity
severity
of anemia, sir, as per WHO classification, the severity of anemia is based on the age. In less than from 6 months to 5 years, less than 10 hemoglobin is mild anemia, and severe anemia is less than 7, sir.
so just quickly
So
bolo severe anemia tha
he's
okay
having severe anemia.
then comment on other RBC parameters quickly September
MCV,
2021
so MCV was also low, MCH was low, so most probably it was microcytic
How
hypochromic
do you
type of picture.
calculate bedside MCV? How do you calculate MCV bedside?
The lower limit of MCV is calculated by 70 plus age of the patient, and upper limit is calculated by 84 plus 0.6 into age of the patient, and it
So
is
MCV was low. What else?
and so MCH was also like lower side, 21. So child was having RDW was increased. That's why
What is a normal RDW?
so 11 to 14 normally.
What is the
So,
normal RBC count?
so 3.5 to 5.5 million.
3.5. 3.5 normal होता है?
4.5 to 5.5. So around.
So you have microcytic anemia and you have high RDW. High RDW means what? What does that mean? If the patient has
anisopoikilocytosis,
good.
the variation
And
in size.
isocytosis. And isocytosis.
Yes, sir. So mostly, so the picture is of microcytic hypochromic anemia type of picture is there. And there's a recent CBC was hemoglobin was 5, TLC platelets all were decreased, and retic count done in June 2024 it was also decreased 0.91%. So it's the reticulocyte count is decreased. It means like there is a decreased production of RBCs. So for that, we have to do like certain investigations like bone marrow aspiration or biopsy.
Can you tell me a sorry? हाँ मुकेश आप बोलो.
Markers of hemolysis भी दिखा दो.
Markers of hemolysis LDH.
Serum bill.
Left hand.
Serum bill was normal.
Yes, it was normal.
बट आपको बताना है ना वो कितना इम्पोर्टेंट क्वेश्चन है. आपको बिलीरुबिन बताना है ना.
Yes, sir, bilirubin and LDH was within normal limits.
बताना है ना वो बहुत जरूरी है.
Yes, yes, sir, yes. So workup was done in our hospital for chronic anemia. So HPLC was done, which was normal. TTG, IG was normal, and direct antiglobulin test and RFT, LFT were within normal limits. Anemia profile was sent. Iron was 42 microgram per deciliter. PI-BC was 130. Transferrin saturation was 35.6%. And ferritin was
cutoff क्या होता है? What is the ferritin cutoff for anemia iron deficiency में क्या cutoff होता है?
Sir, ferritin was 52. So normal levels are around 50 to 300.
किसी का नहीं होता 300. You know there are nutritional anemia guidelines in Indian pediatrics. आपको पता है? Do you know?
Yes.
So their definition is there for iron deficiency. What is the cutoff of ferritin? Will you go back and read it?
Chalo beta, just to appraise right now, less than 5 years if it is less than 12, more than 5 years it is less than 15 without inflammation. If there is some evidence of inflammation, less than 30 for both age groups, that would be meriting the child as a iron deficiency. So it's on higher side. Okay, go ahead.
Sir, folic acid B12 levels were normal. Triple bias serology was negative. So bone marrow aspiration and biopsy was done. So bone marrow aspiration showed the peripheral blood shows microcytic hyperchromic anemia, and there was reduced reticulocyte hemoglobin and mild neutropenia was there. Bone marrow aspirate was grossly hemodilated. On bone marrow biopsy, so hypocellular marrow was there with the overall cellularity of around 15%, which was like reduced for age. Trilineage hematopoiesis is markedly depressed. Reticulin stain was grade 0. Mesenteric stain was there's no collagen deposit seen, and so findings were suggestive of aplastic anemia or bone marrow failure syndrome.
Okay.
See, Kashish, can there be something in the CBC
Yes,
which
sir.
is atypical for a aplastic anemia or a inherited marrow failure? Normally inherited marrow failure में CBC में कुछ दिखता है जो इस केस में नहीं दिख रहा.
Sir,
What are characteristics?
Sir, in case of inherited marrow failures, like aplastic anemia, mostly normocytic anemia is there, and RDW is usually normal. In this case, it's increased.
और क्या होता है? वो तो September 21 maybe the child only had iron deficiency. Okay, what else can be there?
Sir,
what do you see? Macrocytosis, okay?
Macrocytosis.
You see that the MCV is high.
Yes. Okay.
And gradual progression for different cell line involvement, okay? Like typically what you are seeing. But in this child, there is no macrocytosis.
Okay.
Okay. आगे चलो.
So fish for MDS panel was negative, sir. So these investigations are awaited for
now because you are again and again telling MDS, can you tell me just 1 or 2 simple abnormalities that you can see in fish that will be typical in MDS?
So 5q deletion, okay, and the monosomy 7.
Good, very good. आगे चलो.
So these investigations are pending, and That's it, sir. So I prepared a discussion on approach to anemia. So
Approach to anemia, pancytopenia.
I'm sorry, approach to pancytopenia.
Go ahead. So beta, this is very important. जो history से और आपके examination से, so we did not know what you were going to tell us in the bone marrow. So still we could just, our first impression was still the aplastic, which included inherited bone marrow failure syndrome. So it's like if you approach meticulously, you're able to reach to the diagnosis. So MDS is always a possibility. MDS is suspected whenever we have undiagnosed pancytopenias. And when we have, it's like dysplasias in at least 2 lineages, including 10% of the cells. So that the second part is the pathology is going to tell. The third aspect is when we have blast as per the stages, which are usually less than what we see in leukemia. And the fourth aspect is when we have specific cytogenetics. So it is unexplained cytopenias. Yes, MDS has to be considered. So you had to be confident at that level when we were asking why we have included MDS. So you should have said those things. Yes, you are very much right at that point. MDS has to be always appreciated whenever we are suspecting pancytopenias. So it's like a meticulous approach is important. Yes, investigations are going to lead us further, no doubt about it.
So Kashish, we don't want to listen to your theory discussion, but we want to ask you that if you now have this girl, this boy having aplastic anemia in the bone marrow, how will you investigate?
So bone marrow. Okay, sir.
How will you investigate this child where you saw aplastic anemia in the bone marrow?
Sir, first we grade aplastic anemia, whether it's severe or mild or moderate. So, sir, on the basis of Kamet's criteria, if absolute neutrophil count is less than 500 and the reticulocyte count is
बेटा
less
वो
than
तो सीवियरिटी कर रहे हो, मतलब किसी भी एप्लास्टिक एनीमिया के बच्चे को क्या क्या इन्वेस्टिगेशन आप करना चाहोगे to differentiate whether it is acquired, inherited?
Okay. Sir,
वो तो आपने एक
initially, sir, we
definition
have to
बता
send the, yes, sir.
बोलो
Sir, we will send the viral markers to rule out any drug-induced causes or sir, genetic mutations in case of congenital
क्या क्या
hereditary.
genetic?
Sir, genetic mutations, sir.
सीधा जेनेटिक म्यूटेशन पे नहीं जाते बेटा, पहले क्या स्क्रीनिंग टेस्ट क्या करोगे आप? जेनेटिक म्यूटेशन अभी 3 साल से मिल रही है, 4 साल से मिल रही है, उससे पहले आज से for 20 years how are we investigating these children?
Exactly.
What is the base common test?
Yes, sir. Sir,
CBC कराओगे,
viral markers, CBC, LFT,
रेटिक काउंट देखोगे,
B12, yes.
Okay, then what else?
देखोगे. Yes, go ahead.
Sir,
how will you screen for Fanconi and other conditions? How do you screen them?
Fanconi के लिए.
बेटा क्रोमोसोमल ब्रेकेज स्टडी का नाम सुना होगा?
Yes, sir. Chromosomal breakage study. Yes, sir.
क्या होता है? What do you mean by chromo? Can you tell all the students who have come here? 48 students are still sitting there. Can you tell them what do you do in chromosome breakage study? What is chromosome breakage study? Can you tell them briefly? 2 lines.
Yes, sir. Yes, sir. In this study, we will see the breakage of chromosomes. Then we add the mitomycin C and DEB. Then there will be a fusion of the chromosomes.
क्या होता है
with
बेटा
the
ये
C.
माइटोमाइसिन और
So,
बी क्या होता है? इससे क्या होता है सेल में? ये तो बताना
it's
पड़ेगा.
cross linking. They will cause
अरे
cross.
नहीं क्या होता है क्रॉस लिंकिंग? मतलब they induce
Why is
stress.
this happening?
They
Because of
stress and the genome doesn't have the innate capacity to get a kind of repair, so they break. So we are able to see the breaks in the DNA. It's like this. You get it?
yes.
Whenever we induce stress, so it's
normal person will be able to repair this
Repair.
person where there is chromosome fragility. When as sir said, when you put stress, like agents that put stress, they are not able to repair. And that is why their DNA is fragile. Their DNA is fragile. That is why they go into aplastic anemia. And that is why they can develop What? They can develop what? They can develop aplastic anemia. They can develop what else?
Sir, MDS.
MDS, okay. Or what else they can develop? Huh?
PNH.
और कुछ
PNH भूल जा बहन तू. PNH, there is nothing like PNH for MD students. Okay.
Yes.
अरे
No,
कुछ
they will develop aplastic anemia, MDS, or they can develop other cancers because their DNA is very fragile.
Yes, sir. Yes, sir. Yes.
चलो, तो बेटा अगर आप CBS करते हो तो आप क्या रूल आउट करते हो? सिर्फ फेनकनी एनीमिया, बाकी चीजें तो रूल आउट नहीं कर पाते हो ना, तो 50% फिर भी पेंडिंग रह जाती है, जस्ट टू अप्रेज यू. सो इट इज जस्ट दैट 50% ऑफ आस्पेक्टस, बट वी हैव बीन डूइंग दैट. Now it is a whole exome sequencing or targeting sequencing which we should try to do. Go ahead with other investigations which you would like to advise.
Sir, NGS, next generation sequencing.
That's what sir said, na? Whole exome or targeted, that is NGS. Okay, so you'll do NGS for looking for the mutations and rule out other disorders. Okay, then what else? Then what will you do? Suppose a child has no mutation, child's chromosomal breakage is normal, no mutations, no dysmorphology. Now, what is your diagnosis?
Very pertinent question, most commonly encountered.
Sir,
क्या options दोगे parents को आप? क्या options हमारे पास?
If there is a mild to moderate aplastic anemia, so we can wait for 2 to 4 weeks and repeat CBC. If it's improved, then
it's severe. It's severe.
So in severe cases, we should go for bone marrow transplant.
अरे नहीं है उसके पास पैसे, कैसे बात कर रहे हो?
So
if there is no money, sir is saying there is no money. You said you gave the right answer.
Immunosuppressive therapy.
Good.
Right. Go ahead. What is immunosuppressive therapy?
Sir, immunosuppressive therapy basically we like cyclosporin.
Kashish, 1 second. Your child has aplastic anemia. There is no neutrophil. Sir is telling severe aplastic anemia, and you are giving immunosuppressive therapy. Why?
No, sir. Basically, immunosuppressive therapy we give before the stem cell transfusion.
No. Sir is saying there is no money. You can't do a hematopoietic stem cell transplant.
Yes,
Forget transplant. Now you are giving immunosuppressive. Why you are giving immunosuppressive therapy to a child who is already immunosuppressed?
Sorry, sir. So anti-thymocyte globulin.
Why you are giving anti-thymocyte and cyclosporin?
Because sir, child is having pancytopenia, so immunity is decreased. So
you will give more immunity decreasing drugs.
बता बेटा, बोल आराम से, शांति से बोलो. You are right, but बोलो कैसे? You have to explain.
It's because, see, we don't have time, so I'll quickly tell. It is because idiopathic aplastic anemia is a immune-mediated disease. Your immune system is acting against your bone marrow and killing the bone marrow. So by giving immunosuppressive therapy, you are suppressing that immune system that is killing your bone marrow. Okay? You have to understand this, beta. If you don't know why idiopathic aplastic anemia is happening, then you are actually giving immunosuppressive drugs to a child who is severely neutropenic. Okay, or you do transplant. Best is transplant. As sir said, no money. If you can't do transplant, no donor, no money, then you go for immunosuppressive therapy. Okay. Now, suppose this child has Fanconi anemia. Suppose you did chromosomal breakage, it is positive. How will you treat?
Sir, we can give anabolic steroids.
अरे अब बोलो transplant. अब anabolic steroid पे आ गया.
Transplant.
अब transplant is the best choice. अब it's like if it doesn't have money, आपने anabolic steroid दे दिए, क्या chances है response आने के? 20%, कोई 30 बोल देगा ज्यादा से ज्यादा, and that too we don't know कितना आएगा, partial आएगा, complete response आएगा, कितने दिनों तक रहेगा. After sometimes उनके anabolic steroids के side effect आ जाएंगे, say after about 5-6 years. So it's not a wise therapy. Transplant is definitely the therapy of choice in when career. But this is what Dr. Manas is trying to ask you.
Okay.
So I think it's more than 1 hour, Dr. Mukesh.
Sir.
So if you feel that it is okay, if anybody else has any questions, or they want to ask any questions to Kashish, or they want to ask any question for Dr. Mukesh or for me, then you can put in the chat box. We will just ask one last question to Kashish. Kashish, commonest cause of pancytopenia, what do you see in community?
Sir, megaloblastic anemia.
नहीं बेटा, जो कॉमनेस दिखता है सोसाइटी में.
Pancytopenia, sir, drug-induced viral infection, because of viral infection. Epstein-Barr virus, sir.
So either you will see, related to B12 folic acid deficiencies, or you will see it related to infections, that you will have severe
EBV,
cytopenia. Sometimes they will recover. And for a hematologist, either it is a leukemia or it is a aplastic anemia that can present with pancytopenia.
Yes.
Okay, so you have to have a stepwise approach. Do a CBC, peripheral smear, retic count, rule out infections, do a bone marrow aspiration and biopsy, and then you will be able to make a correct diagnosis. Okay? Dr. Mukesh, any last words from you?
Right. So I would just like to summarize. If you have an idiopathic aplastic anemia, the first therapy of choice is mass sibling donor transplant. No doubt about it. Suppose we don't have a mass sibling donor or cost is a concern, then immunosuppressive therapy, in which we give ATG along with cyclosporine. So cyclosporine we give for 6 months to maybe longer periods because of the LMIC setting, no middle income setting. Chances of response for ATG are about say 40 to 50%, not beyond that. And in this 40, 2/3 of them are partial responders, 1/3 of them are complete responders. And it's a long fight. When we give ATG, it's not that simple. And some of them may evolve into malignancy or MDS later on, which we need to follow up. So I think this is all I have to say. Okay. Right, fine.
Thank you. Thank you, Dr. Mukesh.
Thank you, sir.